Well, hello everyone, and welcome to this evening's discussion on the psychotropic effects and plasma concentrations of CBD with and without THC. For those of you new to our program, I'm the CEO of Physicians Research Center Plus. It has three areas of expertise. SALIS is our phase 2 to 4 clinical study pillar. Buds Info is our analytics pillar, and Cerium, our education pillar at PRC. Cerium's designed for the busy healthcare provider who wants to understand cannabis and its derivatives through the lens of science. Next slide, Jahan. We'd like to thank you for taking the time to join us today and to engage with us on this topic and to see what Cerium can offer. Scan this QR code if you haven't done so already. I know some of you have participated before. If you've filled out our survey, thank you very much. For those new or who haven't done it yet, please participate in the survey. It's designed to understand healthcare providers that we serve and to improve our program. So also listed here at the bottom of the QR code is our website if you want to learn more about PRC Trials Plus. So, Jahan, why they might be hopefully scanning this, I'll introduce you and Dr. Malloy. So, Dr. Phil Malloy is a rheumatologist who's recently retired from clinical practice in the Massachusetts area, but remains very active in caring for patients and has been working with us, PRC, for maybe 2 years already. Dr. Jahan Marku is a cannabinoid researcher who has worked in the cannabis area for probably 20 years and has been working with me probably for about 5 on different projects. And Dr. Len Kamen, who's not here, who's usually with us participating from Jefferson University. He is probably on some beautiful island somewhere for the beginning of the year. So I'm going to hand it over to Dr. Marku and to Dr. Malloy for this evening's topic. Dr. Marku, do you have any announcements before we begin, or we're just going to dive in?
I think we're just going to dive in.
Excellent.
Meetings now.
Oh. Be sure to mute yourself as you enter the room. Yes, so just as a friendly reminder,
No, I just muted myself.
So Mary needs.
all right, so just a universal mute control there. All right, so just as a reminder for Journal Club, this is to support healthcare professionals with the discussion of published research, and we do our best to approach each paper with consistency, fairness, and transparency. So today for this journal club, we're going to discuss a paper entitled Cannabidiol Increases Psychotropic Effects and Plasma Concentrations of Delta-9 Tetrahydrocannabinol Without Improving Its Analgesic Properties. A very tempting title to speculate on, and it was published in the Journal of Clinical Pharmacology Therapies in 2024. Dr. Malloy, feel free to jump in any time, but I'll do a first pass at this. What is the problem and what is known about it so far? So there are products on the market that are formulated with CBD and THC. One such product is Sativex, and this is formulated with a 1-to-1 ratio of THC to CBD, and it's an oral mucosal spray. It's an oral mucosal spray that goes under the tongue, and it's absorbed buccally and goes right to the brain. And they put CBD in there to block the intoxicating properties or adverse effects of THC. And there's a lot of data, maybe 10,000, 20,000, 30,000 patient years of data. This product has been around for 20 years, approved in dozens of countries. Of course, it's approved in Mexico and Canada, but not the US. We also hear a lot about the entourage effect, how the sum of the parts of the cannabis plant are more than the individual components. And that might be true in more ways than one. Clearly, THC by itself versus THC with other things does different stuff. And, Isaac Newton probably said it best. If you want to determine the direction a system is going, you have to add up all the forces. The other issue that confounds cannabis data is the expectancy bias. Consumers, in some ways, are conditioned to experience what they are told to experience. If you tell someone this thing will give you energy, they might consume it and then run around the block thinking it gave them energy. If you tell them it's good for sleep, they might take it and then go to sleep. It's like the placebo effect, and it's definitely an issue when a lot of cannabis products. Another thing is that we are very poor predictors of the effects of cannabinoids. When we are administered or take THC and we say, as studies have shown, try to rate our highness, our impairment level, and then go in a driving simulator, we are way off. We are not even close to guessing how high we are. We are too out of it to know how out of it we are in many ways. And so you start to think about all these trends, and then you have lots of THC CBD products on the market, all formulated at different ratios, different ways of consuming them. And you think about, okay, well, there's an entourage effect, there's an expectancy bias, and people are poor predictors of their own impairment when it comes to cannabinoids, or even just the effects of them. I think this causes a number of issues for trying to determine what ratio or what product works best for a certain person. And the other issue we want to talk about too has to do with cannabis and THC. But Dr. Malay, I want to pause there. If you have any comments on this particular slide.
I just want to comment that most of these combination products that we get, or that our patients get, or our friends or people who are asking us for advice, um, are in an oral product, and it's a single dose. You're not taking, unlike the study protocol, which we'll talk about in a second, where you time and separate the CBD from the THC. Most products that you buy on the shelf now, one gummy, several products, two, three, four compounds, molecules in there, taken all at once, simultaneously.
Absolutely. And the other issue we're facing is that cannabis is not a single substance. And I try to think of an analogy, and I only have imperfect ones, but here goes. I like to drink coffee at night. It's relaxing. Some people might say, well, wait a minute, doesn't it have caffeine in it? Not all coffee. Some coffee is decaffeinated. So to think of coffee even as a single substance, some has caffeine in it, some does not. We can think about tea. There's herbal tea, there's caffeinated tea. Tea is not a single substance. When we think about cannabis, sometimes in the literature and the way it's talked about, it is, when it's convenient, talked about a single substance, and at other times, it's talked about something else. And within that, THC, and again, as a molecular biologist, someone who studied cannabinoid receptors, worked and characterized different versions of THC, nothing annoys me more than people not understanding the subtle nuances of molecular pharmacology. And THC is a classification. It's not a compound. It's like talking about dogs. And all dogs are not Boston Terriers. All dogs are not Labradors, right? And so when we think about using the term THC, sometimes it's not a very precise term. It can mean any tetrahydrocannabinol. Delta 9 THC gets a little more specific. I mean, there's only 9 or so isomers in that classification of what we would call delta 9. So again, we also have this issue of many, many compounds, what we call them, and what we think of them. So transitioning to that, those principles into what has published research actually demonstrated about THC and CBD. Well, in the classic academic prose, CBD can enhance and/or inhibit the activities of THC. So what do we mean by this? It depends how it's administered, where it's administered, and to what it's administered. So When you think about basic research, you may notice some subtle differences between a plastic petri dish that is inanimate and yourself. You're somewhat larger, slightly more complex, but maybe you're just as inactive. You just sit there, right? But CBD, in some basic research studies, can augment levels of endocannabinoids. It actually inhibits the degradation of endocannabinoids in research studies, which can stimulate trip channels, which can counteract THC's effect on glutamate. So one of the things THC does, very well documented, gets in your brain and it says, oh, you got all this stuff going on. Let's shut that down. Let's slow that down. No, let's slow down that glutamate trafficking, slow that glutamate signaling. CBD can come along and say, no, 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 let's keep it going. It's like two traffic wardens arguing over the flow of traffic. So that might be an example of CBD inhibiting the activities of THC. It can counteract through the stimulation of trip channels the effect of THC on inhibiting glutamate transmission. CBD, for example, can act at serotonin receptors, 5-HT1A. Do not confuse those with 5-HT2A, which are the targets of completely other drugs. But the 5-HT1A is known for its anti-anxiety properties. So here we might have a thing, okay, CBD is inhibiting THC's acute THC exposure's effect on anxiety. Right, that could be one instance. The next one of the studies there from 1975 was done in Brazil, and Brazil has a rich history of CBD research. Long before it was cool or anyone cared, researchers in Brazil were all over CBD. And we're actually in a bit of a scientific debt to some of the things they found. Just nobody really listened that hard because they actually showed this in a study that CBD could increase the time to onset, intensity, and duration of THC intoxication in 1975. But other researchers with more tightly formulated products like Sativex, a 1-to-1 ratio administered at the same time under the tongue, not swallowed, not orally, not inhaled, again, absorbed buccally, showed much different effects. It showed greater pain relief than THC with less impairment. It showed greater in different types of pain relief and improvements in sleep and cancer pain, and even reducing abnormalities in psychomotor performance with schizophrenia. Those bottom three bullet points are just three of the many studies over the last 20 years with the extracts known as Sativex. And if you're unfamiliar with Sativex, they grow CBD-rich plants, THC-rich plants, make a CO2 extract, combine them, mix them up with ethanol, add a little peppermint oil for palatability, and there you have the spray that meets pharmaceutical standards and is licensed as a pharmaceutical drug in over 30 countries, excluding the US. So, Dr. Malloy, I have talked a lot about the background here. I would just love it if you would talk about a little bit of how this study was done as the clinician, and we move into the clinical part.
Let's talk about the study design, since it's really important when we get to the conclusion slides to see what did they do and who did they enroll. This is a randomized, prospective, double-blind, placebo-controlled study. The details are on the last bullet. 37 healthy volunteers who've used cannabis, but no more than once a month. So they were occasional, not heavy or daily cannabis users. I think they chose this group to make sure that there would not be a low threshold of intolerance. So they are filtering for people who have already tried it and are tolerant of it. The third bullet is really, really crucial. And we talked about that earlier today, us as a team here. There's a big difference between enrolling and studying pain patients. I'm a rheumatologist. I spent my whole career seeing a lot of patients who are in chronic pain. That was a big part of all doctors, I guess, but especially rheumatologists, it seems. Chronic pain patients are different from enrolling pain-free, healthy, normal controls and then subjecting them to noxious stimuli as you would do in an animal study. There is a long history of these noxious stimuli that can involve electricity, cold, pressure. You could put a needle on my arm and so forth. There are ways to apply a noxious stimulus that are standardized, and there are ways to capture an outcome from that, like how much pain the person is experiencing. That is just, I would like to emphasize that that is a totally different study than enrolling patients with chronic pain and then giving them a substance and measuring if they're getting better or not better. So I'm taking healthy, pain-free people, I'm poking them, I'm applying something to them, and in this case, I'm applying a host of different combinations of products at different doses. So the interventions are at the last bullet. There was a group, just so that you know a little bit more of the details. There was a group that got placebo, everything. So on no active product. Um, there were two dosing per session, per study session. There were two dosings because for reasons that are complicated to go into, there are reasons to believe that CBD can occupy certain receptors and it's better to, theoretically, it may be preferred to have it on board before THC or vice versa. So the doses of the CBD and the THC were separated by 30 minutes. Ask yourself if your patients would comply with that regimen. I asked myself that. Most of my patients who are taking gummies, no matter what compounds are in that, want to swallow one thing, a one time, because they're doing it several times a day anyhow. So the other four groups, besides the group that got just placebo, there was a fixed dose. Everybody got the same dose of THC. It was 9 milligrams. Then there were groups that got 10, 30, or 450 milligrams, or just THC only. See, the middle small bullet there is there was a group that got active THC followed by placebo CBD. So the only active compound on board there, we're teasing out the isolated effect from THC. It was double blinded, nobody knew, so everybody had to take all these different pills at different times. And the researcher and the subjects didn't know what they were on. And then the doses of CBD were 10, 30, and 450. So that was what the study was. And the next slide will show you what was. So I would like to congratulate the researchers for thinking of this study and doing it. It's better than other. We don't have a lot of information on this, despite some shortcomings. Like they studied healthy patients, not chronic pain patients. So what did they measure after they gave an input to these patients? What was the output that they measured? Well, they had, it wasn't just do you feel high, there were formal questionnaires on mood, alertness, anxiety, concentration, alertness, so forth, and feeling high. There are different validated scales that these patients subjected. As you can see from the fourth bullet, they filled them out twice pre-dose, and then at 1 hour, 2 hours, 3 hours, 4 hours, and 6 hours post-dose. So the third bullet down, psychomotor and cognitive effects, body sway, adaptive tracking, attention, perception, reaction times, memory, they were all, so it's pretty comprehensive, the things they did to these patients. Autonomic pain is related to cortisol levels. Pain indirectly is related to if your heart rate's going up or down. Prolactin, when I read this paper the first time, I said, what the heck are they looking at prolactin for? And it turns out there is a literature that THC and CBD can interact with prolactin. It's a surrogate measure of cannabinoid effect on dopamine, something I didn't know before this study. So it's a surrogate measure of is this intervention, whatever arm you're studying. All patients got all the arms, so they came back a week later, they came back again and got a different recipe. A week later, they came back, got a different recipe. So all 37 subjects got all these doses. just if you were wondering. If you read the paper, pressure, cold, electrical stimuli, that is very standard in both animal and human studies. PTT, if you see that abbreviation, is pain tolerance threshold. When does it start hurting? When do you feel it? Is it uncomfortable now? Tell me when to stop. It's your pain threshold. Pharmacokinetics is blood levels, simple as that. So they check blood levels of the appropriate compounds and metabolites of interest. Okay, that I hope I didn't butcher this and that you sort of have an idea of how the study was done and who was studied. Let's go to the next one. Here's who was studied, a little bit more detail. Seems like every study has who were they table at the beginning, their age, their height, their weight, their BMI, their sex distribution, their race, and so forth. This is who they were. Seems like you have to include this to get stuff published now anyhow. So go ahead, next one. You're looking at it. So let's talk about the results. And if you do read this, I encourage you to download the article. I believe it's a free open, you don't have to pay for or sign up for anything. I'll leave your email. The tables and the graphs are interesting. Here's an example of, I think this is figure 1 in the article. So if you can read, I'll just mention what's on this paper, and then we'll pick one of these graphs to take a deeper dive into, because there's too much data on here. It would take all night for us to really go through everything. But top left, A, is visual analog scale for attentiveness. B, on the right-hand side of that, is feeling high. This was the tool, the metric, the questionnaire they gave patients on how high do you feel. That's a pretty interesting result. We'll go into that a deeper dive in the next slide, and so forth. Body sway. So you can read what the metrics were. And the P is down below. The black circles, the lines that are attached to the black circles are people who got no active ingredients. And as you can see from A and C and D, they did what you would think an inactive substance would do. The blue square just got THC only, and all the placebo, all the CBD tablets were blanks, were placebos. Um,
And
and
it,
so forth.
we will post this online. So if you want to come back this slide and read it, pause the screen. These will be available on YouTube or through your society.
Yeah. So there's on the left what these 6 graphs are, and let's look at one of them. Let's just pick one arbitrarily and
I picked this
say,
one.
yeah, so we picked this one because it's kind of interesting. This is a funny title. How do researchers actually come up with their titles? And I have a pet peeve that you shouldn't say what the conclusions of a study are in the title. But they did here. They said it changed the blood levels without affecting pain. So adding CBD, the title of this paper actually is if you add CBD to THC, you get higher blood levels of THC, which is shown really interestingly on this slide, because the yellowish, mustard color yellow one is the highest dose of CBD. And the area under the curve is substantially larger than all the other lower doses of it. So you can see that the they feel higher and the dose is higher, probably because of the blood level of THC. The second part of the title of the study, without impacting pain. It had no effect on pain. And I'd like to pause again when, if you do go back and read this interesting study again, I don't think the authors of the study did a good enough job in distinguishing, painting the picture up front and distinguishing this whole big picture of the CBD attenuate the side effects. Are we talking about side effects of THC? Or are we talking about the efficacy in terms of pain relief? And they sort of blend that together in the paper if you read it. If you read this paper again, my advice would be to separate in your own mind. Are they talking about side effects, one mitigating side effects or enhancing beneficial effects, maybe. Because really, that's the paper is looking at both things in the context of blood levels. They had a lot of metrics. There's a lot of data in the paper.
And there's a lot more figures too, including 2 supplemental files, so don't miss those if you want to do some homework and fun reading.
Yeah.
Another thing, Dr. Malloy, that really struck me was the degree of variability. If you look at the red squares or the mustard stars, you see these huge error bars. And so, error bars usually go both ways. And so there are some people who were not impacted at all, or maybe no difference in THC, and some people where this was like kapow, a huge difference. And I think that for me was a very striking thing, that whether it was THC 9 milligrams and 30 milligrams in red, or THC 9 milligrams and CBD 450 milligrams, we see these huge variations in experiences, at least in how high they feel. And again, just remind people, this study was a bit contrived, right? You take CBD followed by THC 30 minutes later. But I found that to be very, very surprising.
I think we know this already, that you can give a drug at a certain dose to one patient and or 5 patients in a row and sort of get an average or expected response. And then you give it to somebody who either has no response or a crazy outlying response. And there's just a lot of variability, and that's what is shown in this graph.
All right, so I won't alert the media just yet. All right.
All right.
So
There's statistical difference between those, just with those big confidence intervals,
for
or
group
particularly
selection,
between like 30 and 450.
the only
Well, they
one that
didn't.
reached statistical significance, I believe, we can double check, is a THC 9 milligram with CBD 450. So the yellow, the area under the curve was significant. So the other ones, again, did not reach significance, perhaps due to the high intra variability.
Compared to placebo, but
Right.
compared to each
Well,
other, were there any
no,
significant differences?
They did not,
there
I
was
don't think
no
they did in
formal
ANOVA.
analysis.
Yeah.
Yeah, so you're asking if the 30 milligram was different from the 450 milligram clinically, and the answer was it was not analyzed or reported. Good question, obviously.
That's
Yeah.
useless to me then.
Yeah.
But
Well, it's useless if you're going to recommend a dose to a patient, but it's not useless to learn concepts. It's not helping pain. The blood level's higher for sure, and it's not helping pain.
Mm. And again,
Better
this
than,
was just one of the scales that they looked at.
yeah.
Oh, yes, Dr. Viner, thanks for raising your hand. Go ahead.
Yes, I had a question.
Oop, I think you muted. You muted.
There we go. Sorry about that. I'm concerned about the time. Well, I had two questions. One is the time. Oral CBD takes longer to, I mean, 3 hours to me isn't enough. They only studied it 6 to 8 hours out. And I've read CBD can take a week or so to work for some things, to count. So I don't know about the time. I'm not sure they studied this long enough. You can't say CBD didn't work for pain if you only studied it for 6 hours after an oral dose. I mean, it's not like they smoked the THC, which the level drops quick. So that's one thing. And then the other thing is, clearly 450 is going to do the cytochrome P and then raise the THC level. But I've had patients with a lot of high neurologic noise from THC. In other words, chronic high dose THC users who do a tiny bit, low dose of CBD, RSO, top it, and they feel it right away. So it's sort of like having the amphetamine or Adderall without all the twitching and ticks, because the CBD will relax the functional connectivity by decreasing the glutamate. So anyway, obviously it's going to help enhance THC's effect. So I agree with the article, but I question the whole design's a little bit funny, but I like the conclusions. Now that's different than psychosis, because I think they're talking about euphoria or feeling high, which by itself is hard to define. Because in the old days, euphoria was a bad symptom. It meant in MS you were nearly demented, and euphoria was a bad prognosis in MS. But of course, CBD helps antipsychotic effects of THC, which is a mental side effect. As I'm a psychiatrist, I study that. So I think it's good. They got to be. I think they could have done a better job of what they were measuring about feeling high besides just the VAS scale. So did it, because it dissociates? Did it relax them? Did it, you know, was it euphoric, or was it less agitation and anxiety and paranoia? So thank you.
Nope, that's great. And to clarify, they did recruit people who were occasional cannabis users, so they might have left a little bit too much interpretation for what is that high feeling. But we're going to move to some of the
I,
other.
oh,
Oh,
can
go
I
ahead,
make a
Molly.
comment
Yeah.
here? Um, your comments, thank you very much, Mark. They did, the timing was chosen so that THC, they have different absorption rates or whatever. They did address that in the supplemental stuff, and they said they chose it so that peak blood level theoretically would occur simultaneously for these two compounds. That was the rationale for separating the dosing. And the rationale for stopping at 6 hours was this is a single dose study. Cannabinoids being so lipophilic, you would think if it was a daily user, there would be accumulation, and then you would have to have endpoints that will weigh out, like you suggested. But in a single dose study, they tried to justify that in healthy subjects with a single dose, um, they were making a case that 6 or 8 hours is going to be enough. Whether,
Yep.
how do you know without, if
Yeah.
they didn't look, how do you know?
And
Yeah, well, I think we all know a single dose isn't going to be that helpful for pain. But anyhow, okay. Thank you though for your clarification.
I agree as well, and that's why I think they looked at this induced pain, not at chronic pain models, which it might take longer to see an effect. But there were some other interesting effects. The one that was interesting to me, given over just last year, there was some ongoing research about the cardiovascular risk or safety profile of using cannabis, very broad term. And what they found was the largest increase in beats per minute with this 450 milligrams of CBD 30 minutes later, administering THC. That's where they saw the mustard star line, this significant increase over other areas, which I thought was pretty interesting, mostly just because there's a lot of discussion on how does cannabis, broad term, affect the heart, the cardiovascular system. And you can find literature on either side of this. And cardio
Yeah.
myocyte models and petri dishes, it can have a protective effect. But again, as you move outward into epidemiology, more questions get raised. But
Remember, these patients are getting noxious stimuli at this time, which is why the placebo group heart rate and cortisol is changing too, because despite the fact whatever they're taking, placebo or some milligram dose, they're being exposed to noxious stimuli, painful stimuli.
An excellent point. You're
Yeah,
absolutely right.
yeah. Okay.
um, just make sure we have any other questions from the chat. All right, so we'll move on. Happy to come back
Yeah.
to this later, but just to say, One of the things that gives this study credibility, I think, is in the plasma prolactin. They saw what they thought they would see there, and also with the cortisol as sort of their predicted, I think, distribution of responses. Um,
Yeah.
Pharmacokinetics, a lot of questions coming in to the old chat about that. What is going on in the blood? So plasma THC, if you can see through the error bars, is increasing at the times you think it would, and particularly the 11-hydroxy metabolite over in B, upper right-hand corner. Again, our friend, the mustard yellow star line, is that trend is a bit larger. The area on the curve is much larger than the other ones, and that is, again, hints at CBD is being administered first. It is occupying the CYP enzymes that metabolize THC. Therefore, there aren't a lot of things to metabolize THC further. And so what we might be witnessing is just potentially, conceptually, a classic drug-drug interaction. One drug is delaying the metabolism of another. And I think this may help to explain some of the effects. You have THC around for a longer period of time. Its effects are lasting longer, and maybe longer than the participants are used to having THC go about its business in the body.
You
Yeah.
would you speculate that daily users would, I mean, just speculating, would have a different result?
I think people have more experience titrating their dose and
Yeah.
their experience. I think they would have a different rating on this effect. They might have experienced something like this before or be used to it, or it might even be reaching the desired effect. I think that was a question that wasn't necessarily asked is the peak effect desirable that you experience, or is it undesirable? I think they sort of made that assumption for the participants, but I don't know that an experienced user would maybe notice this as much, especially if they're experienced with edibles and they're used to taking edibles. But again, it's pure speculation.
Yeah, it's a good time to reflect on a prior journal club. There was the methodology of the driving under the influence of cannabis one. Some of you were on it, and there was no fixed dose given. The subjects were told to smoke till you get a certain level of perceived subjective highness, and then they were put in a driving stimulator channel. So everybody reached that at a different dose, whether depending on who they were and the level of their daily consumption up until then or whatever. That's another way to do a study. That's all.
Yeah. And, and one thing that's interesting here too is that the lower doses of CBD showed minimal or no significant changes. So this was clearly an effect of taking a large amount of CBD, and by large I mean half a gram or so, 450 milligrams of pure CBD, followed by 9 milligrams of THC. So this is just a comparison summary. We didn't go through all the data tables. There's more data tables in the study. Like I said, there's 2 supplemental files as well in addition to the published research. But along the top, we have the outcome, so what they looked at, THC alone, and then the 3 other dosing platforms. And with pain relief, right, THC alone, minor improvement with the noxious stimuli. So we give you some THC, we zap you, ask you how painful it was. But again, with the other compounds, there was really no change in the perception of pain relief when challenged. And I guess, as someone who did their PhD in basic research, I find this to be a bit like an animal study in many ways. They challenged the creature with and without different drugs versus, a person with a certain condition. What was interesting was the plasma levels of THC. We see those increase in a dose response way. So the more CBD there is, the more THC there is in plasma levels. When we talk about postural instability, as rated in this study, we really see significant changes around the high dose CBD with THC. And again, similarly with the feeling high effect.
Question on those, I'm sorry.
Yeah, go ahead.
Um, on the second thing where it's THC plus CBD 10, it says no change, slight improvement, minimal. Is that compared to THC alone or is that compared to the placebo?
I believe it would be compared to the placebo group. Or maybe it is THC. I'd have to check. We can go back and look at the graph. But or actually I believe that might be no, I think that is in relations to
Yeah, Jayan, what's the question? Because I can look it up. What's the question again?
compares is the THC CBD 10 milligram, no change in pain relief. Is that related to THC alone or compared to placebo?
Ah, okay. I
Because
will look again.
It's a
Yeah,
good
because
question.
the other ones, when you look at it, like the slight increase, it's like slight increase versus baseline for THC alone, plasma THC levels, no change for minor versus minor impairment. I would find that odd that it went from minor to no change, so that's why.
I mean, yeah, that um but that was part of their conclusion, I think, too, was that there was no benefit to pain when you add CBD into the mix. Again, not administered at the same time, not as part of the same formulation, but this contrived, staggered delivery form. Uh, we will, I just want to double check because I don't want to speak. I don't want to go on the record. This is going out on YouTube, so don't want to. But it's a good question. But let me think. I don't know if we have much else. Let's talk about strengths and weaknesses. We have Teresa's hot on the case to double check our graph here. So we might have some answers here. So maybe this is here in the pain relief second bullet point. CBD did not enhance these properties at any dose. And so perhaps the pain thresholds were not significantly improved by THC. So I think that graph that we generated last week or that table was a comparison to THC itself.
So Jayan, if you want, you have to pull the table 2, and if you wanted to actually look at the paper all live with everyone, because it has, within that table, if you wanted to look at it. For pain, right? That's what we're looking at.
Yeah. All right. So 1 second. Let me pull that up.
And the caveat is in these healthy, non-chronic pain patients, in this study environment at these doses, there was no measurable analgesic effect by adding CBD.
Right.
Okay. So I'm just going to flip through the paper.
It's table 2 all the way at the end.
Table 2?
Yep.
Oh, table 2, not figure 2. All right.
Nope, table 2.
There,
Oh, here we go. Table 2, continued cold pain.
Go all the way down, yep. The pain tolerance thresholds, that's what you're talking about?
Yeah, pain tolerance.
Yeah, so if
Yeah.
you look, yeah, it's towards the end of page 9.
Yep.
yeah,
All right, so we see
So
here
you're looking at the electrical stare or the pressure pain
I
tolerance?
have pain tolerance threshold and the threshold here. So, yeah. So we only really, we see mostly with this compared to THC that there are really no differences. Maybe with that one. And then if we go to the next ones, the cold pain threshold, we
yeah,
also don't see differences as well.
yeah.
So they almost, it kind of looks like there might be, I guess it would depend on that, maybe that 450 and the pressure pain tolerance threshold. Something interesting's happening there, but it didn't quite reach it.
Yeah, I think that, and then the differences between them, right? So if you look at the THC
Yeah.
plus CBD 10 milligram between the electrical stare and then the same dosage with the pressure pain, like you actually see that one, with the 30 milligrams, there's a big difference between those outcome measures, right? Where The 9 milligram, it's not as big of a difference. Now that's visual, right? They didn't do those analyses, and that's what I think was asked earlier.
Yeah. So and they have these different types of pain measurements that they're looking at. And I think overall, their trend was that CBD did not necessarily improve THC. In some cases, it, like heat pain, it doesn't look like it did much for heat pain, for example.
All right.
All right, moving, and I think this ties nicely into some of the strengths and weaknesses with the paper we talked about as well. So, in the interest of time, I'm just going to move a little bit further, and then we can open it up. So, what I take away from this is that the timing and administration forms may be more important than we previously thought, right? Because this shows that if you play with the timing a little bit, take a bunch of this, 30 minutes later, take some of that, you could have an unexpected effect. And we wrote a little blog about this, looking at other research, some of the information we include here. Happy to share that around. But again, CBD looks like, depending on how it's administered, when it's administered, can either enhance or inhibit certain effects of THC. Some of the strengths and weaknesses Dr. Malloy and I and Teresa discussed was one for me was that they didn't do the opposite. They didn't test taking THC 30 minutes later, followed by CBD, even in one group. Would have been interesting to do the opposite for me, because I was thinking real world scenario, what do people do? They, as like on online forums, so I took too much THC, so I use CBD. People aren't usually, I'm going to prophylactically, intentionally take CBD and then THC. It does happen, but I'm saying most of the anecdotes out there are about people self-administering CBD after THC exposure. I thought it was interesting they only used one fixed dose of THC. I think that most people feel something at 5. Almost everyone in clinical study feels something at 10 or 9, as they use in the study. It would have been interesting to see 2.5 milligrams. Do people feel something that they normally don't feel at those dosing? And Dr. Malloy, you made a great point earlier, this last bullet point. Chronic pain and acute pain are very different.
Peripheral neurologic activity, neurotransmitters, what's happening centrally, totally different. Totally different.
And so we're talking about healthy, pain-free subjects in this study who are put through some mild discomfort and asked to rate it. So, which is completely different. And I think, Mark, you brought up some good points about, well, why don't they look at it, the effect of CBD over a week on pain? I think that's would be the challenge with a chronic condition, is that they would have to probably look at it for extended period of time versus an acute pain. So does it's like, does cannabis help when you stub your toe with that acute pain? The study has answered the age-old question that not really, but it doesn't speak to chronic pain conditions. And so this opens up again one of our discussion points, and I think we've heard some murmurs about it. But Dr. Malloy, you had posited this question and talked about, well, what do you do when a patient or a loved one comes to you and says, well, what THC CBD ratio should I start with?
Well, first of all, this paper doesn't help answer that question, because clinicians here, we don't treat healthy asymptomatic people with evoked noxious stimulus. That's not who we're treating. We're treating people with chronic mental health issues, chronic pain. Those are our patients. So this study really, I can't take results and just extrapolate them, just pick them up and put them into my exam room when I'm with a patient. I think we have other literature on chronic pain patients. It gives, with minimal justification, gives reasonable state of the knowledge advice. The advice that's in the rheumatology journals is, if pain is the reason people are having this conversation with you, as opposed to anxiety, sleep, appetite, pain's the reason. there are societies that have gone on record saying if you're going to recommend, start with 2.5 and 2.5, 2.5 of each at bedtime with a single dose and move up from there. There are titration things after a certain amount of time with no benefit and no side effects. That's in naive patients. So obviously it depends on your patient. Are they experienced users already? Yeah, I wouldn't start at that same dose in an experienced user.
It also might be expensive to get 450 milligrams of pure CBD.
Well, it doesn't work anyhow,
There we go.
except for feeling high.
Um, so one thing I think is a take-home message, and just generally, is that cannabinoid combinations can be unpredictable when you mess with routes of administration and timing. For me, the results shown today were, I think, I think unpredictable is a good word. We look at those huge error bars. We look at what happens as you add more CBD into the biology. And I think for me, it brings into question the stacking of products and using of different products, and encouraging everyone to keep track if they have, if you're using products, if patients using products, keep track of that timing. I think that's becoming an important factor. And again, as someone who's been more and more interested in the toxicology and the safety of these products, I would say that at least now we found one thing we can say maybe don't do. Maybe a future warning label might be on CBD: warning, do not take THC 30 minutes after consuming. Um, Please wait 1 hour before using THC. Uh, just like before going swimming after eating, I guess.
Yeah, another myth.
So this is an ongoing field of research. The story is far from over. If you want to take a peek at clinicaltrials.gov, there are so many THC CBD combo studies. We just grabbed the first couple we saw that looked interesting, and these are their titles. They're comparing THC CBD formulations. They're comparing THC and CBD in memory. They're looking at the differences in combinations among gender. They're looking at chronic pain with this combination. So I think this is, again, a very active area of research. My very first paper I ever published was on THC and CBD combinations in a cell model. So this is a area I have been intrigued with for a long time. And I'm really happy that we're living to see the day where there are so many clinical studies that are exploring these combinations. And we're going to gather again the first Tuesday in February, and we're going to talk about some research around the what we're calling decoding semi-synthetic cannabinoid toxicity. So we're going to talk a bit about some of these derivatives, compounds that are made from hemp, CBD, derived into other things. The most complicated way I could say it is neopo-cannabinoids, which are new man-made cannabinoids that don't typically occur in nature in any significant amount. For March, April, and May, we are looking at some interesting research articles on perioperative cannabis use. So things like related to surgery, pre and post-surgery, dental procedures, as well as maybe taking a dive into some of the newest trends in laboratory testing. And there's definitely been some interest in what labs are doing, what tests they're doing, how mold and bacteria limits might be changing in different states. But again, we're also open to any suggestions you have now, in the future, about topics you'd like us to explore. And if there's a research article on it, we're happy to try and dig it up. And I would say with that, happy to take a moment to answer any other questions you have. I appreciate you all showing up. We couldn't have a journal club without the club. So
Yeah, and Jayhan, do you want to just put up the QR code again?
Yeah, I did say I would
It
go
looks
back
like,
in this
yeah, no, it
slide.
looks like a few people filled it out, so I want to just thank them. I appreciate anyone who participates in this. This is great.
Gotcha. See you guys next month. Happy New Year.
Are there any more comments though? Are they good?
Well,
Thank you.
we had, yeah, thank you everyone for your comments, your questions, your time. We appreciate it. And we'll just sign off shortly. But again, thank you so much for joining us and look forward to seeing you all at the next one.
And tell your interested colleagues to kind of share the link with them.
Thank you.
All right.